Welcome to the Deep Dive. We're here to break down complex topics into, well, the really crucial bits you need.
That's the plan.
And today, our focus is squarely on lung abscesses. Think of it as a targeted look at those localized pockets of infection in the lungs.
Exactly. We've got some solid revision notes here, aiming for a high-yield overview.
So our mission is basically to pull out the absolute must-knows, make it clear, concise, and hopefully memorable, especially if you got exams on the horizon.
Let's do it. So fundamentally, a lung abscess, it's a contained collection of pus in the lung, right? It forms a cavity.
Filled with nasty stuff.
Pretty much. Dead cells, inflammatory material, and usually bacteria. Understanding it means looking at the causes, how it develops, how we spot it, and of course, how we treat it.
Okay, so let's start at the beginning. What actually sets the stage for these things, the main triggers?
Well, the number one cause often is aspiration.
Aspiration, you mean inhaling stuff?
Exactly. Inhaling stuff from your mouth or even your stomach, it's kind of an aha moment when you realize something like minor reflux, especially in someone vulnerable, could lead to this.
Right, not something you'd immediately think of.
Not always. And then you also see it complicating other lung infections like pneumonia or bronchiectasis.
Weakened immune systems.
Definitely. Things like alcoholism or, any immunodeficiency state make people much more susceptible.
Okay, and inside the lung, what's actually happening? What are the key features of this abscess?
So what happens is something called liquefactive necrosis. Basically, the lung tissue breaks down.
Liquefies it.
Essentially, yes. And it forms a cavity, usually bigger than about 2 centimeters, and it's filled with all that debris and fluid we mentioned.
And the body just lets this happen.
Well, it tries to fight back. It forms a sort of wall, a fibrous capsule around the abscess to contain it.
Oh, okay.
And sometimes, instead of one big one, you can get multiple smaller abscesses. We call that necrotizing pneumonia.
Okay. And I saw something about primary versus secondary.
Right. So primary abscesses, they happen in lungs that maybe already had some disease. That's about 60% of cases. Secondary ones, they're complications from something else, maybe like an infected blood clot traveling to the lung.
Got it. You emphasize aspiration. Are there other sort of specific pathways?
Yes. Aspiration of those anaerobic bacteria from the mouth, the ones that hate oxygen, is a big one, leading to aspiration pneumonia, which can then become an abscess.
Makes sense. Bad dental hygiene connection there.
Potentially, yes. But other things, too. Inhaling a foreign object, for instance. Or bacteria spreading through the blood. Bacteremia.
Like from an infection elsewhere.
Exactly. Or from infected heart valves, like tricuspid endocarditis. Or even an infection spreading directly from nearby, like a liver abscess pushing through.
Wow, okay.
And don't forget things like lung cancer blocking an airway. Or even just trauma to the chest.
Right. So let's circle back to aspiration. Why does it happen more in some people? What are those specific risk factors?
Good question. Anything that impairs consciousness is a major risk.
Like being drunk or high or sedated.
Precisely. Alcohol, drugs, general anesthesia, even certain neurological disorders that affect awareness or swallowing.
And swallowing difficulties, right? Dysphagia.
Yes, dysphagia is a huge risk factor. And as we touched on, being immunocompromised, the lungs just can't clear the aspirated stuff effectively.
Okay. So when an infection does take hold, who are the usual bacterial suspects?
It's often a mix. You get anaerobes, think Peptostreptococcus, Bacteroides, Fusobacterium. Those thrive in the mouth, low oxygen spots. And then you have the aerobes needing oxygen. Staph aureus is a common one. Strep pyogenes, Haemophilus influenza, Pseudomonas.
Pseudomonas, isn't that often hospital-acquired?
It can be, or in people with underlying lung issues. Klebsiella is another one. Oh, and Burkholderia cepacia, you often see that linked with cystic fibrosis.
Interesting specific links.
Yeah, and even Pasteurella multisida, sometimes from pets, believe it or not.
Wow. Any non-bacterial causes?
Less common, but yes. Mycobacteria, like TB, can cause cavities that look like abscesses. Fungi too, Aspergillus, Cryptococcus, and even parasites like Entamoeba histolytica.
Okay, quite a range. Any way to remember the main groups?
You could think A to P, so A for anaerobes, A for aerobes, then P for the others parasites, plus the myco and fungi.
A to P, anaerobes, aerobes, parasites, others.
Got it. So beyond the direct causes, what about general risk factors? Who's more likely to get one?
We've hit some already. Alcoholism, drug misuse, big links there. Smoking, definitely.
And you mentioned dental hygiene earlier.
Yes, surprisingly important. Part dental health means more bacteria ready to be aspirated than impaired consciousness, anesthesia, diabetes mellitus,
Diabetes.
dysphagia, severe gum disease, neurological issues like stroke that affect swallowing.
It's quite a list.
It is. Immunosuppression, congenital heart disease, chronic lung conditions like CF or bronchiectasis.
Is there a mnemonic for those risk factors? They seem quite diverse.
There is one floating around. Sand-ding helps cover the bases.
Sanding. Okay, break it down. S for stroke, A for anesthesia, N for neuro conditions, D for diabetes, another D for dental issues, I for impaired consciousness, N for, well, neuro, again, if it's G for general anesthesia overlaps, but reinforces the point. It's not perfect, but it jogs the memory.
Sand-dinging.
Yeah.
Stroke, anesthesia, neuro, diabetes, dental, impaired, general.
Okay, helpful. So we know the risks, the bugs. How does it actually unfold, the pathophysiology?
Right. So step by step, bacteria get into the lower airways, usually via aspiration. If your lung defenses are down, the bacteria multiply. Inflammation kicks off.
The infection starts.
Exactly. And that inflammation leads to tissue destruction. That's the necrosis part. Then the cavity forms and fills with pus, the bacteria, dead cells, inflammatory cells. Often it starts as aspiration pneumonia and just progresses.
Okay. And can it spread other ways besides aspiration?
Yes. Through the blood that's hematogenous spread, like from endocarditis, direct extension, maybe from an empyema next door. Or if a tumor blocks an airway, infection can build up behind it and form an abscess.
And is it always multiple types of bacteria? Often polymicrobial, yes, a mix. But sometimes it can be just one type, monomicrobial. Staph aureus, Klebsiella, Pseudomonas can sometimes do it on their own.
Right. So if someone comes in and you suspect this, what else could it be? What's on the differential diagnosis list?
Good point. You need to rule out other things that can look similar on imaging or cause similar symptoms.
Like other infections.
Definitely. TB is a classic mimic. Opportunistic infections in immunocompromised people, but also lung cancer, some types can form cavities.
Ah, okay, malignancy.
Yes. Then there are things like a pulmonary infarct, dead lung tissue from a clot, or vasculitis like GPA, which can cause cavities. Sarcoidosis sometimes does. An infected bronchogenic cyst. Other fungal infections.
Lots to consider. Any tip for remembering those categories?
Maybe think broad categories. Infections, TB, fungal, opportunistic. Growth chests like cavitating cancer. Blockages, pulmonary embolism infarction. Inflammation, vasculitis, sarcoidosis. And other cavities like infected cysts.
Infections, growths, blockages, inflammation, other cavities. Okay, that helps frame it. How common are lung abscesses, actually, epidemiology-wise?
You know, specific UK data is a bit scarce, but generally they're considered relatively rare compared to, say, standard community-acquired pneumonia.
So not something you see every day?
Probably not. Their frequency really depends on how common those risk factors are in the population, healthcare access, that sort of thing. You do see them more in older people, those with existing lung disease, or the immunocompromised.
Makes sense. Okay, let's talk presentation. How does someone with a lung abscess typically feel or look? Symptoms.
It's often quite an insidious onset, but key symptoms include a persistent fever and a productive cough, and the sputum. It's often described as foul-smelling or tasting. That's a big clue.
Foul sputum. What else?
Chest pain, often pleuritic, worse on breathing. Fatigue, just feeling wiped out. Weight loss, night sweats, general malaise.
Like TB symptoms almost.
There's overlap, definitely. Sometimes coughing up blood hemoptysis and shortness of breath, dyspnea.
Is there a mnemonic for these symptoms too?
There's one called feverish pecat wine. It's a bit elaborate, maybe.
Let's hear it. Feverish pecat wine.
F fever, E expectoration, productive cough. V vomit-like sputum, foul. E malaise, feeling unwell. R night sweats, I weight loss, S shortness of breath, H hemoptysis. Then P chest pain, C chronic nature, A fatigue, T temperature, high. The wine part seems tacked on, but the feverish pecat covers most key things.
Feverish pecat. Okay, useful. And what about signs on examination? What might a doctor find?
You might find dullness when tapping, percussing over the abscess area, maybe bronchial breathing sounds through the stethoscope. In chronic cases, finger clubbing can develop.
Killing, okay.
Also, fast breathing rate, tachypnea, fast heart rate, tachycardia, maybe signs of dehydration, a high temperature. Localized dullness and crackles, crepitations are common findings over the affected lung area, and you'd also look for clues like poor teeth or signs of endocarditis.
Got it. So clinical picture plus those signs.
Yeah.
What investigations nail the diagnosis?
It's really a combination. Imaging is key. Microbiology is essential. and the overall clinical picture.
Imaging first. Chest X-ray.
Usually start there, yes. You're looking for an opacity, a shadow, often with an air fluid level inside it. That's quite characteristic.
Yeah, fluid level, okay.
But a CT scan of the chest gives much more detail. It's better for seeing the cavity, the wall, and if there are multiple small ones, or if there's an underlying issue like a tumor.
And the microbiology. Sputum.
Definitely sputum cultures. Try to get a good sample before starting antibiotics if possible. Blood cultures, too, to check for bacteria in the bloodstream. This helps identify the bug and guides antibiotic choice.
What about blood tests?
You'd do a full blood count, often shows high white cells, maybe anemia from chronic illness, kidney and liver function tests for baseline health. Inflammatory markers like ESR and CRP will almost always be high.
Any other special tests?
Sometimes, if things aren't clear or you suspect an obstruction like cancer, a bronchoscopy might be needed.
Setting a camera down.
Exactly. To look directly and get samples like washings or biopsies. Less often, maybe a needle aspiration through the chest wall if other methods don't yield answers. And depending on risk factors, HIV testing might be relevant.
Okay, comprehensive workup. Once you've confirmed it's a lung abscess, what's the plan? How do you manage it?
The cornerstone is antibiotics, and usually for quite a long time.
How long?
Typically starting with IV antibiotics in hospital for maybe 2 or 3 weeks, then switching to oral antibiotics for another 4 to 8 weeks, sometimes even longer.
Weeks and weeks, okay. What antibiotics?
It depends on the likely bugs and local resistance patterns. Often start broad spectrum, maybe a beta-lactam with a beta-lactamase inhibitor like coamoxiclav, or a cephalosporin plus clindamycin, which has good anaerobic cover. Then you tailor it once you get culture results back.
Right, narrow it down if you can.
Exactly. And supportive care is vital too. Pain relief, oxygen if needed, keeping the patient hydrated. Physiotherapy, especially postural drainage, can help clear the secretions.
Does surgery ever come into it?
Sometimes, yes. If the abscess is very large, if it doesn't respond to antibiotics, or if complications develop.
Like what kind of surgery?
Options include draining the abscess, either via bronchoscopy or putting a drain in through the chest wall under CT guidance. More rarely, actual lung resection surgery might be needed to remove the affected bit of lung.
Okay. But antibiotics are the mainstay.
Absolutely. They work really well in most cases.
Yeah.
Success rates are high, maybe 80–90%. But you need to monitor closely. If it's resolving very slowly, you have to think again, could it be something else like cancer or a resistant bug?
Right. Good success rate, though. What's the overall outlook of the prognosis?
Generally pretty good, especially if caught and treated promptly. As I said, around 90% cure rate with the right antibiotics.
So most people recover fully.
The majority do, yes. But it depends on things like how severe it was, the person's other health problems, comorbidities, how quickly they got treatment, and if they actually take the full course of antibiotics.
Compliance is key.
Absolutely. Things that make the prognosis worse include being older, having serious underlying conditions, having it alongside a bad pneumonia, reduced consciousness, or infection with certain nasty bugs like Pseudomonas, Staph aureus, or Klebsiella.
Okay. And what are the potential bad things that can happen? The complications?
Well, the abscess could rupture into the space around the lung, the pleural space.
No.
That causes an empyema, basically pus collecting there.
Nasty.
Yes. You can get scarring in the lung tissue afterwards. Sometimes a bronchopleural fistula develops an abnormal connection between the airway and that pleural space.
Leaking air.
Essentially, yes. And the infection can spread into the bloodstream, causing septicemia, which is life-threatening, or rarely spread via the blood to cause abscesses elsewhere in the body, like the brain.
Okay, so serious potential downsides if not managed well. Let's try and wrap this up then. What are the absolute key takeaways for a lung abscess?
Okay, key points. It's a localized lung infection forming a pus-filled cavity.
Often from aspiration.
Very often from aspiration, yeah. Diagnosis relies heavily on imaging X-ray, showing that air fluid level, CT, for detail, plus microbiology to find the bug.
Treatment is long-course antibiotics tailored to the bacteria.
That's the core. Surgery is reserved for specific situations, and prognosis is generally good, 90% cure rate, if treated properly and promptly.
And important to remember the risk factors, like impaired consciousness, poor dental health, immunosuppression.
Exactly. And be aware of those potential complications like empyema or fistula.
Great summary. It really highlights how something like aspiration, maybe linked to dental health or consciousness level, can snowball into a serious lung issue. Definitely something to keep in mind.
It is indeed.
Fantastic. That was a really clear run-through. For everyone listening who wants to dive deeper or needs more resources, especially for MSRA prep, definitely check out pastthemsra.com and freemsra.com.
Good resources there.
Thanks again for joining us on this deep dive.